Welcome everyone. Today we'll discuss the second question. That is, uh, in 2015, there was a question: what is the basic principle of screening and its uses and abuses of screening? So, coming to the basic principle of screening, the basic principle of screening are guidelines that help determine when and how to conduct screening programs for diseases in a population. These principles ensures that screening is effective, ethical, and beneficial for individuals and the broader healthcare system. Screening is the process of identifying undiagnosed diseases or conditions people who do not yet to show symptoms, with the goal of early detection and intervention. The principles of screening were originally proposed by Wilson and Jungner in 1968 under the WHO and remain foundational to modern screening practices. So here are the basic principles. First is the condition should be an important health problem. The disease or condition being screened should have significant public health implications. This means it should be common, cause substantial morbidity or mortality, or be a major health burden on the population. Example is cancer, breast cancer and colorectal cancer, cardiovascular disease, diabetes. Second principle, there should be an acceptance treatment for patients with recognized diseases. There must be an effective and treatment available that improves outcome if the condition is detected early. Early detection should lead to a better prognosis compared to the treatment started later after symptoms develop. Example is early stage cancers are more treatable than the late stage cancers. Number third principle is the natural history of the condition should be well understood. The disease's progression should be understood well enough to know which stages are most suitable for screening and interventions. This includes knowing the preclinical phases before symptoms appear and when treatment can prevent the progression. Example is understanding the progression from precancerous lesions to invasive cancers helps to determine appropriate screening intervals. Fourth principle is that disease should have a latent or early symptomatic stage. Screening is only beneficial if there is a stage during which the disease can be detected before clinical symptoms appear and if early detection leads to a better outcomes. Example, mammography detects breast cancer at early stages, often before symptoms like lumps are felt. Then coming to the fifth principle. Fifth principle is there should be a suitable and acceptable test. The screening test used should be accurate, reliable, and acceptable to the population. It must have good sensitivity, ability to correctly identify those in the disease, and specificity. Specificity is ability to correctly identify those without the disease. Okay, with a low rate of false positive and negatives. Example is pap smear for cervical cancer screening are relatively simple, non-invasive, and have high sensitivity for detecting precancerous lesions. Number six principle. Sixth principle is the screening test should be safe and cost effective. Okay, and the test should be safe and cause minimal harm and be affordable. It should not expose individual to unnecessary risks such as radiation or invasive procedures unless the benefit is significantly outweighs the risk. Example, screening of high blood pressure using a simple sphygmomanometer is safe, non-invasive, and inexpensive. Number seven principle is the test should be acceptable to the population. The screening process should not cause significant discomfort, stigma, or harm to the individuals. Participation in the screening program should be voluntary, and the test must be culturally and socially acceptable to the population being screened. Example, colonoscopy for colorectal cancer screening, while invasive, is widely accepted due to its high effectiveness in detecting polyps and early cancers. Number eight principle is facilities for diagnosing and treatment should be available. Facilities for diagnosis and treatment should be available. Adequate resource must be in place to confirm the diagnosis and provide treatment to those who test positive. Screening is futile without the ability to follow up with confirmatory testing and effective treatment. Example is, if screening detects early stage cancer, healthcare systems should have the necessary surgical or medical facilities to treat the patients promptly. Number 9 principle. There should be an agreed upon policy on whom to treat as patients. There should be clear guidelines should exist regarding who qualifies for treatment based on screening results. This prevents unnecessary treatment of individuals with borderline ambiguous results and ensures that those most likely to benefit from treatment are identified. Example is cholesterol screening, specific cutoff points for intervention like lifestyle changes, statin therapy, or well established based on the cardiovascular risk. Then coming to the 10th principle, the cost of case finding should be economical balanced in relation to overall healthcare expenditure. The cost of the screening program should be justified in relation to its benefits. This includes not just the cost of the screening itself, but the cost of the follow-up testing, diagnosis, and treatment of individuals who screen positive. Okay. Example: screening diabetes using FBS is cost-effective because early management of diabetes prevents expensive complications like kidney failure, cardiovascular disease. Then number 11. It is screening should be continuous process, not a once and for all project. The screening programs should be a part of ongoing effort to monitor and manage public health. Periodic risk screening may be necessary depending upon the conditions and the population risk factors. Example, regular screening for cervical cancer using pap smear for HPV testing is recommended every few years for women with certain age groups. Then additional modern consideration, risk stratification. Screening programs should consider risk stratification targeting higher risk populations based on age, family history, and lifestyle factors rather than applying for the same screening intervals for everyone. This ensures that resources are used efficiently. Then minimizing the harm. Screening can sometimes lead to overdiagnosis and unnecessary anxiety and treatment, especially in cases where detected conditions might never progress to cause harm. Modern screening programs aim to minimize these potential harms by redefining criteria for interventions. Then informed consent and autonomy. Individuals should be provided with an information about the benefits and risk of screening and have the autonomy to make informed choices about whether or not to participate in the screening programs. Then coming to the second part of the question, that is uses and abuses of screening. Okay, uses and abuses of screening refer to appropriate and inappropriate application of screening programs in healthcare. Screening can be a powerful tool for early detection and prevention of diseases, but if used improperly, that can lead to harm, unnecessary cost, and ethical issues. Here is an analysis of both the uses and abuses of screening. Then uses of screening. Early detection of diseases. Screening allows for the detection of diseases at an early and often asymptomatic stages when they are more treatable. This can lead to a better outcome and improve survival rates. Example is mammography for early detection of breast cancer significantly increases the chances of survival by catching the disease before it spreads. Number 2 is prevention of disease progression. Screening can identify precursor or early form of diseases, allowing to interventions that prevent the progression to more severe stages. Example, pap smear and SPB testing detect precancerous lesions in the cervix, allowing the treatment before the cervical cancer develops. Number 3 is improved public health outcomes. Population-wide screening programs can reduce the overall disease burden in a community by identifying high-risk individuals and treating them early, preventing widespread complications and deaths. Then number 4 is cost-effective healthcare. When implemented appropriately, screening can be cost-effective by preventing the need for more intensive and expensive treatment later the disease processes. Example is screening of high blood pressure and managing it early reduces the need for the costly treatment related to the heart attacks and stroke. Number five is informed decision making. Screening provides individuals with valuable information about their health, empowering them to make informed decisions about preventable actions or lifestyle changes. Example, screening for colorectal cancer helps individuals to understand the risk and taking preventive actions such as dietary changes and increased surveillance. Number six is improved quality of life by detecting the conditions that could lead to significant morbidity. If left untreated, screening can improve the quality of life individuals who might otherwise suffer from preventable complications. Like screening of diabetic retinopathy in individuals with diabetes prevent blindness and maintaining the quality of life. Number seven is in, target public health interventions. Screening programs help identify high-risk groups with the population. Example is smoker individuals with a population with a family history of certain cancers, allowing for targeted interventions. Example is lung cancer screening using low-dose CT scans or high-risk populations like heavy smokers reduces the lung cancer mortality. Then coming to the abuses of screening. First is overdiagnosis. Overdiagnosis occurs when screening identifies diseases or conditions that would not have caused harm during the patient's lifetime. This can lead to unnecessary treatment anxiety and reduced quality of life. PSA, that is prostate-specific antigen screening for prostate cancer, can detect slow-growing tumor that may never become clinically significant, leading to overtreatment, including surgery or radiation. Then is false positive. Screening tests can produce false positive results, leading to unnecessary follow-up tests, invasive procedures, and psychological distress. False positive can increase the healthcare cost and patient anxiety without any real benefits. Like mammograms sometimes result in false positive, leading to unnecessary biopsy or surgery for benign conditions. Then false negative result can occur when screening fails to detect the disease that is present, giving the patient a false sense of security that this can delay the correct diagnosis and treatment. Example is pap smear may occasionally miss early signs of cervical cancer, leading to delays in treatment and women who believe they are disease free. Now for is overuse of unnecessary screening. In some cases, screening is applied to the population where the benefits is unclear or the risk of harm outweighs the potential advantages. This can lead to the increased healthcare cost without corresponding the benefits. Like a routine full body CT scan in healthy individuals without symptoms can expose people to unnecessary radiation without providing clear health benefits, increasing the risk of cancer from radiation exposures. Then psychological harms. The process of screening, especially if the results are abnormal, can cause significant psychological distress, including anxiety and depression, even when the final diagnosis turns out to be benign. Example is false positive result can on a cancer screening test may cause unnecessary stress and anxiety while awaiting follow-up testing and procedures. Uh, then is screening in low risk populations. When screening is applied to a population with low risk for a particular disease, that likelihood of false positive increases, while the benefits of detecting diseases early are minimal. Like screening of colorectal cancer in young, low-risk individuals may lead to unnecessary colonoscopy and complications, while the actual risk of developing cancer is minimal in that age group. Then is unethical implementations. Screening programs that do not adequately inform patient to the potential risks, benefits, and uncertainties may violate principles of autonomy and informed consent. Like screening programs implemented without proper patient education, particularly in vulnerable populations, may lead to individuals to make decisions they do not fully understand or agree with. Then is healthcare resource strength. Unnecessary or widespread screening of low-risk individuals can place a burden on healthcare systems, diverting the resources from more effective interventions or care for individuals with known conditions. Like mass screening of certain cancers in populations with minimal risk could divert healthcare resources from more pressing population health needs like managing chronic disease or infective outbreaks. Then opportunity cost. Time and resource spent on unnecessary screening program may mean that more effective healthcare interventions are underfunded or underutilized. Underutilized. Like overinvestment in screening conditions like osteoporosis in younger, healthy individuals may take away the resources from the more beneficial interventions like vaccination programs and diabetes management. Then, how to balance uses and abuses of screening. The key effective screening is ensuring that it is applied in the way that maximizes the benefits and minimizes the harm. This includes careful selection of screening population. Screening should be targeted at individuals who are higher risk for the diseases rather than a general population, unless the disease is highly prevalent, and the screening test is highly accurate. Cost effectiveness analysis. Screening programs should be evaluated for their cost effectiveness, ensuring that benefits of early detection outweigh the cost of testing, follow-up, and treatment. Informed consent. Patients should be fully informed about the potential risks, benefits of screening, including the possibility of overdiagnosis, false positive, and false negative. Then regular review and updates of screening guidelines. Guidelines should be based on the latest research and adjusted as new evidence emerges to prevent or overuse and misuse the screening. Conclusion. So, conclusion is screening is a powerful tool in modern medicine for the early detection of diseases and prevention of disease progression. However, its misuse can lead to significant harm, including overdiagnosis, unnecessary treatment, and healthcare resource strain. The challenge is to apply screening judiciously, balancing the benefits of an early detection with the potential harms of unnecessary interventions, while ensuring that the patient are fully informed about the consent to the process. Okay, thank you.